afternoon, everyone. It seems it's not afternoon, anyways. Uh, we'll now begin with our next session, Strengthening AI Evaluation, Policy and Practice Pathway. I would like to introduce our speakers, Dr. Annie Hartley, Professor and Director of the Laboratory for Intelligent Global Health and Humanitarian Response Technologies, Mr. Anubhav Arora, Co-Executive Director, Programs and Platforms, Noora Health, Dr. Gokul Krishnan, Senior Research Scientist, Center for Responsible AI, IIT-Madras, Dr. 𝐏𝐚𝐧𝐞𝐥, Core Faculty, Assistant Professor, Koita Centre for Digital Health, IIT Bombay, Dr. Subhasis Banerjee, Professor and Head of Department of Computer Science, Ashoka University, and our moderator is Dr. Surankar Datta, Simons Ashoka Fellow, Ashoka University. He will be moderating a session. I would like to hand over to Dr. Surankar.
Good afternoon and welcome to the session on the very interesting topic of today, strengthening AI evaluation, policy and practice pathways. Am I audible there? Okay, cool. So I think I don't need the mic then. So the motivation of the session is very straightforward. Today, if you look at the entire sector, AI is rapidly moving from research into policy. And we are seeing pilots turning into actual deployments in the clinical setups. But evaluation has not really kept pace with deployment. Most of the AI tools today, which we see in our clinics, they are often using static benchmarks, and they also are doing one-time validations, which even though the systems are like dynamic and very data dependent, very sensitive, the models which we see, they do change over time, and it often leads to a lot of performance drift and harmful unintended consequences. So today in the next 60 minutes, and we'll try to keep it within time so that you guys can have lunch at the perfect time, we are going to address three very important questions. So the first one is, what evidence is actually enough to deploy an AI tool in any hospital or a clinic? The second question is, what are the failures in evaluation which often happen, and which of those failures often cause harm for our patients? And most importantly, which we are not seeing happening in most health systems, is that after deployment of these AI solutions, what are the specific things which need to be monitored and evaluated so that the safety and trust in these AI models can persist over time? So our goal today is to not only discuss the principles, but also to move towards policy relevant pathways for deploying responsible AI. To set the stage for the conversation, I'm delighted to introduce Dr. Annie Hartley, who is the Director of Laboratory for Intelligent Global Health and Humanitarian Response Technologies, or the LIGHT Lab. She is internationally recognized for advancing AI evaluation beyond laboratory benchmarks into real-world policy-relevant, resource-constrained health system evaluations. And her work spans a lot of things. Few of them are large-scale clinical trials, humanitarian deployments, and she leads major initiatives like MOVE, which she's going to talk about, which is a massive open online validation evaluation, which you can see on the screen. And she also has started something called as DISCO, which is a very distributed, privacy-preserving platform that enables collaborative evaluation and learning across institutions without centralizing the sensitive healthcare data. So at a time when India and other LMICs are asking not only whether AI really works, but how to evaluate it responsibly at scale, I think Dr. Hartley's work will provide all of us a concrete blueprint for lifecycle-based and governance-linked, equity-centered AI evaluation. So with this, Dr. Hartley, over to you.
Okay, well, thank you very much. You can see I'm walking very carefully. It's the first time I'm wearing a sari. And speaking about evaluation, you shouldn't do it at a once-off. It's a continuous process. And if you think I'm looking good right now, it wasn't the thing this morning. I left my hotel room, and I was stopped very promptly in front of the elevators. And the guy who was cleaning some rooms, he said, "You are not leaving a hotel like this." And he rewrapped and redraped my sari. And this is, why am I telling you this? Well, it's actually the theme of what we are speaking about today. It is the value of experts' critical evaluation, right? Because I looked way stupid this morning, and it was dangerous to I think to um, the Indian society, how I draped my sari. So I before I left the room, I was stopped, checked, and evaluated, and this actually made it much better. And this is exactly what we need to do with our AI tools as well. This is the theme of, it's a little bit of a silly introduction, but it's the very serious theme of our initiative that we are adopting everywhere. It's a way of life for me at the moment. It is MOVE. It's a massive open online validation and evaluation program. And it's something that we actually also are launching in India for the first time. And yesterday was our inaugural validatathon, where we are making a marathon of validation. And we'll tell you a little bit about what are some of the results that we had yesterday as well. Now, you can see that the subtext there is about actively building. So we are already doing participatory workshops, making sure that people are being involved in the process from the beginning through evaluating. These tools, like AI tools that can speak to us for the first time, these are tools that can speak to experts in the language that they are using every day, and sometimes in their own language, in Hindi and in languages that I'm speaking in South Africa, for example, in Xhosa and Swahili and in others. And this means that we can actually interact with these tools, not just to ask them questions, but to prompt them in ways that will nudge them into different behaviors. And this means that it opens up for experts that are doctors who are using these tools to nudge them into behaviors that are responsible. And it gives them control and ownership of these tools as well. So we want them to be the active builders, to deliver clinically validated tools that are adapted to their setting. When we're nudging them, we want to nudge them into the context that they should be used, because we know that we cannot trust tools that are built on data that doesn't represent our needs. And this is about what we're trying to do. It's about calibrating our trust in these tools. You're very excited, and we should be excited. Any doctor knows. I'm a doctor as well, and I know that the most valuable thing that I can give to my patient, beyond anything, I can have as many resources as I like, the most valuable thing that I have to give to my patient is by far information. Nothing trumps information. You can have as many resources as you like. If you don't tell people when to use the resource, how to use it, or why, it's absolutely useless. And so that's why chatbots are actually extremely valuable, and we should be excited about their potential. But we should also calibrate our excitement with evidence as well as experience, and most importantly, ownership. We need to own the tools so that we can make sure that we can evaluate them and iterate them when we find them most valuable. So what are we doing here? Basically, we try to make scalable and implementable tools that are provably impactful, right? So we try to prove that they are impactful, and we use that evidence to make sure that they are continually learning from that. It is a cycle. And we do this through collaboration, right? So this is what we do as a lab, but this is also representative of the MOVE. We start with clinical trials here at the COP, and the clinical trials that we are doing are expandable and also learning clinical trials, call them platform trials, that allow us to follow one protocol and then actually spread it out into different use cases or places, from our several implementations in Africa to now in India as well. And then we make sure when we collect the data that it is ethically collected. I think Shravanka was telling you a little bit about some of our initiatives there, the initiative called DISCO. And we then use that data that's continually collected from our implementations to then feed into the model. It is obvious that we should do this, right? But we weren't doing this on a standard basis before, because tools weren't learners. And these tools are now actively learned. So we collect the data, we make sure that we can integrate them into models in a way that we trust, right? Not just any kind of data. Make sure that these collected data can answer it. And then we can test it back into the field and put it in practice again, and the cycle continues. So we believe in this kind of extreme openness, and make sure that we can have this neutrality in how we are delivering our tools. This is really important, because this whole process doesn't work if the data that we are feeding into it is biased. Maybe it's some big company that is, has a little, let's say, agreement with a pharmaceutical company, right? Like OpenAI maybe has some advertising agreement. And they say, well, every time you're going to say depression, you're going to also recommend my drug, right? If that's the kind of data we are collecting, we can't meaningfully learn from the data. And so we have to be neutral so that we can make sure that the things that we are learning are trustworthy. And this means that we are trying to be agnostic to the data type, the model type that we are using. We're trying to be as open as possible so that we can test everything and we know which model is best for everyone's setting. So when we say agnostic to data, agnostic to model, agnostic to the use case or geography, it means that we can deploy these LLMs to anything, right? You can ask these LLMs anything, right? So we have to test them in this massive way and meet the moment of the size of what we are doing. So just to make this more tangible, when we say we're going to put this into a model, this is the models we are putting them into. We have this pipeline. We call our pipeline Meditron. It is a way to medicalize any open LLM, right? So we can only medicalize or change open LLMs. We can only nudge LLMs that we know how to. They know how they work. It's these open LLMs we'll speak about, and then we use the Move platform to move the models into a new context. And so it's a very simple context. It's a very simple idea where we take this platform and we collaboratively co-develop AI models with expert feedback. So you can just see using that feedback from the clinical trials back into the models and to make sure that this is done on a continuous basis. So just to briefly touch on to Meditron and why this is like a little bit special and why people are using these tools, it's because we value openness. And I'll show you how the doctors that we were interacting with yesterday value openness. Now, there's many open LLMs. You've probably heard of some of these, right? I'm sure everyone here has heard of DeepSeek, had heard of Meta's Llama, Google's Gemma. Mistral is the French version. There's Qwen from, for instance, from China. Now, these are called open LLMs, but they're not really open, right? Some models are actually more open than others. And they're not really open because the things that are being released here are only like a list of numbers, actually. It's how the words are represented as mathematical components in the numbers. These are called weights. These are called actually open weight models. And what we've done as a group in Switzerland, in one of the places where I'm based, we've actually come together as a huge initiative to make the world's first fully open model of this kind of large size called apertus. It's Latin for open. And here we can also calibrate our trust in these models much better because we actually know not just the weights, these numbers that actually mean nothing to us. We also know the actual data that it has been trained on. And so for the first time, you can see it could open not just code weights and the license to use it, but the open training data. So we know the data that it's trained on. And how we do this, no one else is doing this. Why did other people release the data? Well, it's because we're training on naughty data, right? And the data that they're training on is copyright data. And so Meta can't release this data. Google can't release this data. They'll get into trouble. And there's been a whole lot of law cases about it as well. So what we're doing is we're trying to scrape the internet, and this is what the group did. It's a much bigger initiative than Mia, which is playing a part in it. But we actually had the fairly source data where we respected the copyright signals. So if a website says, hey, don't train on copyright, we respect that and we ignore it. It puts us at a huge disadvantage though, right? We may be being very trustworthy in the data sourcing, but we're missing out on all the good stuff, right? So what we have to do now, which is why Move becomes so important, is source high quality feedback to ensure that we can compensate and improve the models with high quality experts information that goes into these models. It's not that much words. It's only a few percentage points. But we still have to work together as a community because these are public goods, and we need to respect the time, the energy, and the physical energy as well, like carbon dioxide, right? To make these tools, it's very extensive in terms of electricity as well. We have to respect the value of these tools as assets for our society, and not just recreate the wheel every single time we want to build a model. We must invest in their utility and value, so that we can ensure that they can be used appropriately. So we take all of these different kinds of open models, and you can only do this with open models. And then we can take data that is representative of your setting, right? And this is important because you know that even though it's like the most populous country, you know that you are a fraction of the available information on the internet in terms of in Hindi or in any other language of the many over 1,000 languages that are spoken here. So this is the same problem that we have in Africa. So that's where I'm representing, of course. But it's a problem that actually is so important that we actually have to take the data that's specially representing our setting and make sure we take that effort to represent, right? And so we make a suite of models that can be tested on any single base, and we can improve them. Like, for instance, we improved the purchase by over 10% in its medical benchmarks by using this kind of information that's carefully curated. And you can see it's expert curated. So this kind of expert curation allows us to better trust the data, because it's not just learning on any old, research paper that may be outdated, but it's learning from things that doctors would approve. We can make a whole lot of different versions. We can have all the features that OpenAI and other big companies have, but they make sure it's multimodal, so it understands images. So it can be voice to voice. Is a little bit hard still at the moment, but we're trying. It can be multilingual, like, for instance, the Pertis is trained on over 1,000 languages. So there's many more work that needs to be done on this. We can also then do it in different sizes. So things fit on your phone all the way to something that needs a server. But these kind of sizing are really important as well, so that you can evaluate the tools, because we need to evaluate not only a single model, but many different kinds of models and many models that people have to use in practice. And if someone is using something on their phone that can't be updated when you see a problem, it's really important to evaluate that much more strongly as well. Okay, so just to be clear, I wanted to be quick because I know that we are all racing toward lunch. So the whole point of the move is to take this kind of suite of open models, not just Meditron, but anything. And we medicalize models and they record. You can't write it. But here we use the move to have this continuous feedback. So it's this continuously learned framework that we are using here. So just to go through this, I wanted to make sure that you just understood the concept here is that the data that we normally have in Africa, as well as in many cases of rural settings, often looks like this. Do you even want to train on this data if it was digitized, right? So we are underrepresented. We will never be as represented as we want. Even on PubMed, less than 3% of PubMed covers the African continent, right? So how much do you think is covering the Indian continent? You'd be surprised at how little, even though there's so many people. And this data that is potentially available will take you like years and billions of dollars to digitize. And even when you do digitize it, it will be outdated and will probably represent an under-resourced setting that doesn't have the aspirational kind of information about the patient that you would want to train on. So we just have to accept that imperfect models are going to be made, and that's how it is, right? Even if we train on the base data, we can, and we have to rather adapt it through use. And that is what Loop is about. It's about nudging the model with expertise. And so this is what we're trying to do, where we take as best data as we can get, we expertly curate the guidelines, we make a Meditron, whatever model is best used in your setting, maybe IIT Delhi or something else comes up, the Hindi model. We can make that as the base model to ensure that it is representing the setting as much as possible. And then use doctors, which get invited yesterday for the validator part, to nudge the models in an expert way. So that is what the move is about. We gathered some of our colleagues here yesterday. We asked them to ask the models difficult clinical questions and then for them to rate the responses, and then they can reap the benefits. We want to make sure, and this is a public good. We're not some commercial entity that's now making money on this or something. We are an academic coalition of people, and we want to make sure that they reap the benefits of what they are implementing here, right? In the end, they're going to get an aligned chatbot that represents their setting. But humans are humans, and they also want to be able to have their time validated in some way. And so they can also use that information. It's their data, co-authorship on publications, certification in AI evaluation, and also some international recognition as AI expertise. So it's all about calibrating our trust with evidence. And I hope that we can further spread this initiative, and you can give us good ideas about who to contact and if you have any idea about how to go about this. But it's about really local ownership. And I think this resonates with people a lot. We can't rely on OpenAI forever. If you're reading the news, there's a whole lot of rumors about how they're using money with inference all the time. There's a very expensive process to ask questions to these models or to infer on them. and they might be losing money. So what is their profit strategy? Are they going to rapidly change their get us all addicted to it, which I am, I'm one of them, and then change the pricing strategy so that it actually becomes unavailable to any of the people who became home? We need to make sure that they are locally owned so that we can align them to our own community standards and make sure that it's not the what they're optimizing in terms of accuracy is not determined by profit margins. We need to make sure our experts that we trust are validating them, that know our guidelines, that know our patients, that know our epidemiology, that we co-create this as a people who are actually going to use it so that they know how to use it and they know how to front it. Make them accountable to ensure that there's transparent public oversight and to ensure that they are dynamically updatable so that they change our changing needs. And finally, that they are adapted simply by a representative evaluation that's coming from our communities and the patients that we are treating. So this is a big initiative already. We have over 20,000 expert questions. We've got those are scenarios that are being tested with over 200,000 experts. We've got many LLMs in various countries with thousands of experts. And here we are really excited to try to roll this out as big as possible in India. It's our biggest initiative that we're trying to do. And we are hoping to have the robust support of anyone who is interested as we're trying to make this a grassroots initiative and to go forward. We have several clinical trial sites, which we are trying to develop as a platform trial, as I've told you before, where several countries can then just add on as we go forward in Ethiopia, Kenya, Rwanda, Tanzania, and in Switzerland and others. And we are looking forward to expanding this. Now, just to end on a last note, because we did the validator-thon yesterday, to show you some results that you might find interesting about what doctors are actually thinking. If we want expert evaluation and we want to make sure we are representing our doctors, who are these doctors and what do they want? And I think it's important that we listen to them and appreciate what they are looking for in these models. We want to see like how much they actually trust them and how much they are using them at the moment. And you can see here that some of these cohort of the doctors that we had here, which is not different, it's not very extreme from what you expect. 75% have moderate to high trust in these models, right? So they already trust them quite a lot, right? But they also, you can see here, we had another one, same cohort of people. How much would you trust them so they can be relevant decision? You can see here, it's kind of red and purple, and red and purple are almost almost what you'd say. And here, they trust them almost as much as a doctor with a fully a degreed doctor, right? With just less than 1% for 1 year of experience. And here, it matches a doctor with between 1 and 5 years. So someone has even completed their residence, right? This is extraordinary. They trusted as much as a colleague that you would normally ask the question to, and a few people trusted more than themselves. But I find this very interesting because if you ask the same question in Europe, it's actually much more skewed towards trusting it more than seeing a doctor, or even more than an average MD colleague, and much more than themselves as well. Why? Because it's more accurate immersive, right? And we are inequitably inaccurate here, and this is the doctors see it and notice it. They also use it sometimes too often. 60% of people are using it often in the clinic, or sometimes too often, which is extraordinary as well. We can't control these tools. They're going to be used whether we like them or not. So we better make sure that we include regulation inside of its evaluation and continuous evaluation as they are being rolled out. You can also see here that over 75% of people do think that it is going to be beneficial. Almost none think it's going to be harmful. Actually, exactly none think it's going to be harmful. This is a hugely beneficial or has a high potential for benefits according to our expert doctors that been had invited, and people recognize it. So we do need to invest in the side of the coverage. And finally, I think it's just two more that were very interesting. Doctors are also very conscious about the risk of bias between commercial models like ChatGPT. So how much do you trust open LLMs versus these closed ones? And you can see here that the people here, over half of the people, so 2/3, right, think that they're equal. So even these small open models that are made by a university versus these massive scale multi-billion-dollar models by OpenAI and others, they actually think that those big models are less trustworthy than the small ones, right? That are less performant because they are smaller, because of this importance of bias. And so we do need to invest in open alternatives because doctors want them. They want them. They do trust them sometimes even more in these big models. And so it's worth it. And so we do need to work together to make sure that they are good quality, and we can only do that through community support. And finally, there was a lot of questions here, so I quickly put these two last ones in. 60% of the doctors this is a kind of opposite, almost sounding results. 60% of the doctors believe that AI should be regulated. So this is like, to what extent do you agree with this statement? So AI tools should be held to the same ethical and safety standards as a licensed medical device, right? So nearly 60% said it should be like regulated. It should have evidence-based. It should be tested in a randomized control trial. It should have FDA or CE marking clearance. They really think that it should be regulated, but very few don't agree with that statement. However, quite oppositely, they also think that over 50%, nearly the same amount, are kind of on the side of the scale, saying that it should be held to the same responsibility standards as you following some Google advice. So even though it should be regulated, right, and certified, they wouldn't hold AI responsible or something if it got wrong. It's the doctor who would be held responsible. And I think that's very interesting. So that was just something that came up a few times, so I thought I'd address it. But I'll leave it here, and very interested to hear your feedback and questions in the panel. So thank you very much for this opportunity, and I'm really excited. I mean, like yesterday, the Validator was so exciting, and to work with this team is a real privilege to be here, and I'm very, very excited to do this. So please reach out if you know anyone who wants to participate as well. Thank you.
I invite Dr. Subhasis Banerjee, Professor and Head of Computer Science at Ashoka University, who brings a critical systems perspective on trust, privacy, evaluation, and transparency, drawing lessons from large-scale digital infrastructures that are directly relevant to healthcare AI. I invite Anubhav Arora, Co-Executive Director for Programs and Platforms at Noora Health, who brings hands-on experience evaluating Gen AI systems for patient and caregiver communication at scale. Dr. Gokul S. Krishnan, Senior Research Scientist at the Center for Responsible AI, or CERI, at IIT-Madras, whose work focuses on building and evaluating trustworthy AI systems. Dr. Kshitij Jadhav, Faculty and Assistant Professor at the Koita Centre for Digital Health at IIT Bombay, working at the interface of LLMs and clinical workflows. Over the next half an hour, let's cut the time short. We will explore how AI evaluation must evolve from static benchmarks to continuous processes. So we'll begin the discussion, and a request for a kind and a big applause for the fantastic panel who have fought the Delhi and Panipat weather to be here with us today. So my first question would directly go to Annie. So Annie, through Move, you just showed us how you have worked in AI evaluation. So what evidence do you want to see before deployment, and how Move is helping in doing so through large-scale evaluations, specifically low-resource settings other than India?
Okay, well, I'm sure you're all sick of my voice. I'm going to keep this short. And I think you saw that my most important thing that I had there with that cycle. So I don't want evidence before deployment. I want evidence continually during deployment. And it's already deployed. It's already deployed. You saw how many people are using it. There's no question about should we deploy it or not. That's not for us to decide. We need evidence, continual evidence, and that's the kind of evidence that I want. Right.
Thank you, Annie. So I'll move to Mr. Anubhav Arora. So Anubhav, at Noora Health, you are using AI-enabled messaging to support mothers and caregivers. So when AI directly communicates with families, what does good evaluation mean to you before you deploy your zip files? And what would make you stop a rollout even if the model performance is, let's say, really good technically?
Thanks. So I'll quickly maybe describe the AI use case that we have at Noora before sharing our evaluation system that we have set up and what good evaluation means for us. So At Noora, simply put, we train patient families to become effective caregivers. The training starts within hospital premises, and then it continues long term via a two-way mobile-based support system. We actually last year built and deployed an AI system which wasn't directly patient-facing, but it was rather supporting our back-end clinical team. So we have a back-end clinical team of nurses and doctors who respond to user questions, thousands of user questions every day, about 10,000 of them every day, in multiple languages and multiple modalities. So we built a system to support that team in responding to those questions. And there's a ton of tasks that a nurse behind the screen has to do. She has to sift through those questions to separate the emergency questions from the routine questions. She has to search our knowledge bank for the appropriate response and then draft the response and send it out. So there were a lot of manual tasks, and we were suffering with slow turnaround times and even some responses that were being sent out, given the high volume. It wasn't satisfactory. So the use case that we really selected as a first use case out of the door was as a co-pilot, as the system that we developed that summarizes the user profile. It summarizes the last 72 hours of conversation that a user has had with the nurse. It pulls the relevant rows from our vetted knowledge bank, and it drafts an initial response that the nurse can then edit before sending out. So there's a human for every response that goes out. But it also helps the nurse with with faster responses, and it helps with the cognitive load. So now answering what a good evaluation means to us, and I think I really resonated with what Dr. Banerjee said. I think two components. One, when we say evaluation, what are we measuring needs to be much broader than just the technical performance, just the immediate output of the model. So that's one, that are we evaluating, what are we evaluating beyond the technical performance? Are we evaluating, product usage metrics? And we follow 4-level frameworks that I can go deeper into. And then, is the AI-enabled tool leading to meaningful interactions, which is product engagement, and then those AI-enabled interactions, are those leading to changes in user perceptions, thoughts, behaviors, and then finally, is the tool leading to the development outcomes, in this case, health outcomes that we all care about. So much broader definition of what we are measuring to assess the quality of the AI application and then improve it. And then second component is the continuous evaluation. It's not about, the initial deployment. The post-deployment monitoring is really difficult, is really resource intensive. It's not easy. But that being a part of the evaluation framework is what I'll define as the second component of a good evaluation system.
Thank you. Coming to Dr. Subhasis Banerjee. Dr. Subhasis, you have often argued that the biggest unresolved issue in healthcare AI is not just privacy and bias, but reliability and how we measure it, especially once systems are deployed in the real world. So, Dr. Banerjee, how should we evaluate and continuously measure the reliability of AI systems in healthcare? And what are we currently, as per you, getting wrong by relying on the static benchmarks and one-time validations which we do?
So I'll start with a caveat. I have no experience in deployment of healthcare systems. So I have built a chest X-ray for COVID detection system that is deployed as a research environment at AIIMS. I've also built a breast cancer detection system that is deployed for clinical trial in the radiology department. I have been working with AI systems for 30 years, starting from my PhD. So what I say is more from a computer science perspective and more theoretical perspective. There's a trouble with AI systems is that the performance evaluation is measured on a data set. And an accuracy measurement on a data set does not translate to reliability. I mean, that's the fundamental problem. So even if you keep augmenting the data set with newer and newer samples, theoretically, you will never ever be able to certify that your data set has become represented, right? So your data set. So for example, our COVID detection system started with 98% accuracy in the peak of COVID. That AIMS director was a co-author of that paper. I think that now it works with about 50% accuracy because of the shift of the data that has happened, and 50% is definitional and random rubbish. That's coin toss. That's how you define random rubbish. For breast cancer, you start with a model that probably are Caucasian breasts, trained on Caucasian breast. You augment it with a huge amount of data collected at AIMS, which will be predominantly North Indian women, a variety of ages. So a Caucasian trained data will fail miserably on the AIMS data set because Indian breasts tend to be fatty. They're called dense breast, right? So in X-ray, they look completely different. Now, if you train on that, suddenly a tribal woman shows up and it goes for a toss. So it'll be very hard in a diverse country like India to say that you've got a representative data set. That's probably never ever going to happen. So even with the shift and reinforcement learning, there'll always be a problem, right? And so the bias is in the representativeness in the data set, whether you have got the entire population built into the data. That's a difficult thing. Now, measurements, the standard way of measurement is accuracy. You augment the data set and measure an accuracy. Right? Now, how do you measure an accuracy? You say that there's a probability of failure. The trouble is that on the input distribution, there is no probability measure. There is no universe defined. Right? A set of all breast cancer images is not even an universe. So it is the probability calculus that we use is misapplied out there. So you can at best do an evaluation on a mechanistical. You can evaluate a model. How does a model behave with respect to a data set? But on a data set, what is this probability distribution is a malformed question. The other way of measuring is RCT. Yeah, the standard way of measuring is RCT. RCT has two problems. There are two very, very famous results that says that they can almost never work. One by Angus Deaton, who is a Nobel laureate in economics. Another is by Julia Pearl, who is a Turing Award in computer science. And both have argued that in the bias variance trade-off, it's impossible to place. So if you keep repeating an RCT, typically you do it only once. But suppose you read it 1,000 times. Will you get the same result? Unless you can argue that an RCT is a misapplied thing. And RCT is valid in a medical domain when you've got supporting evidence from you have a biochemical theory, you've got an immunological theory, you've got several other theories that support an RCT. But testing one data-driven technique with another data-driven technique, I think is troublesome. Right? So I think that evaluation is case-specific. We change from situation to situation. The breast cancer evaluation problem is a little easier than the chatbot evaluation problem, right? A free-form dialogue evaluation problem, I would say, is nearly impossible. So it'll have to be context-specific and rigorous, right? You have to devise new rigorous methods for a context-specific situation. So I'll stop there.
Thank you so much, Banerjee. Taking cue from that, Dr. Gokul Krishnan is here from IIT-Madras. Dr. Gokul, in your recent work, I was looking at your papers, especially the INDICASA paper, which evaluates bias in language models in the Indian context, to even M-Firm, right? which looks at the harm-based fairness in clinical decision support. You have shown that bias is often highly contextual, like Dr. Banerjee just now spoke, and it's often invisible to the standard metrics, right? So before deploying an AI system in healthcare, according to you, what are the fairness and bias evaluations that are absolutely essential but are still routinely skipped in real-world deployments?
Okay, thank you. Like Professor Banerjee was saying right now, right? The static evaluation, having a constant metric, all this sounds like that one fancy mirror in a hotel with the nice lighting. If you go and see there, you look very nice, right? But the reality is far from that at times, right? So some of these metrics are kind of like that. It's good for showcasing when you come up with a new model. All the benchmark metrics, I think most of the panel would agree with me that when I say most of these benchmark metrics are done in a very controlled setting, need not translate to the real world, right? And it's not going to kind of tell how safe it is for real world usage. So fairness being one of the aspects under responsible AI to evaluate also has its own nuances and contextualized versions, right? So for example, when we normally say something like a fairness metric, people go to the group fairness metric where they say that, okay, the model is performing in a similar manner across multiple user groups. But this can be easily fooled, right? So for instance, the especially generative AI based models have a tendency to play safe when it comes to very critical sectors and settings. So if I am going to look at something like an ED triaging, if I say that everyone requires ED care, right? Then your model is kind of like fair with everyone, right? It's just going to say that, hey, everyone requires attention, right? So nobody is looking at the distribution of the years versus no or the ones versus zeros that you have. So now it is more important to look at in a deeper manner, right? Go deeper and figure out what exactly is different among the user groups. So for one instance, it could be confidence scores. So the confidence in which I am predicting yes for one category of users versus the confidence score I present for the other second category of users could be very different, right? Maybe one is like very marginally above 50% and that's why it's getting converted. For the other, it is like 95%. So this is a significant hiccup that can eventually it can move out of distribution also, right? And cause more trouble. The other is to look at, so this was from the MFARM work that I was saying. The other from the Indicasa work that we can borrow is probably to look at the learned representations and how they shift, right? So am I getting similar looking representations from different categories, right? And how similar are they? How dissimilar are they? So these are some of the fairness things that we can look into deeper, but these are never done, right? Not even skipped. These are never done. And this is something which we have proposed. Again, it is extremely contextual. So I am of the opinion that, again, most of the panel would agree with me when I say this, right? It's not like, okay, we have one particular AGI kind of model that will do everything and therefore we don't need to evaluate for each and every task, right? But that kind of exam is required for, that's like telling, okay, the student is good at English, so no need to have a test for social science, right? So there are context, there is contextualization, there is grounding that needs to happen. And this should be evaluated however good the model is, right? So what you are going to use it for, a task A versus task B, it should be evaluated under grounding of these tasks, the fairness or whatever responsible AI aspect you are going to evaluate. I think I'll pause there.
Thank you. So closing the round with Dr. Kshitij Jadhav, who is a physician scientist and also faculty at IIT Bombay. So Dr. Kshitij, you work at the interface of LLMs and clinical workflows. And just now, Dr. Gokul talked about the issues with generative AI. So once a generative AI system is deployed in a hospital, and you also work with a lot of hospitals, right? What should teams in the clinical teams, what should they monitor continuously? And what is a single evaluation step which you think they should prioritize first to avoid the unintended harm, especially with generative models like Dr. Gokul mentioned?
Yeah, so thanks, Urvankar, for the question. So for one thing, what I would like to say is, see, we have to get our models out, because given the country scale that we have, we will always have the less number of doctors in the ecosystem to treat the wide number of patients that we have. So there are a bunch of problems in Gen AI. There's a problem of hallucination, there's a problem of accuracy, there's a problem of drift, and all this happens. But if you ask me, as the single most, that's what you asked me, right? Like the single most problem evaluation framework. So there's this concept of silent but prospective clinical validation with human in the loop evals, where you do the entire. So we say that we have developed a really good world-class model, and we talk about validation studies, but what I'm talking about is silent prospective clinical validation using human in the loop, which means that you deploy the model, but you don't use it in any clinical decision making, right? So you deploy it, you get human feedback, I think, which is one of the things that Move is trying to do, right? Get expert human clinical feedback, really find those edge cases where harm might definitely happen, and then evaluate whether your models are equipped to address those decently well. If not, then you'll have to retrain. But you also put a boundary as how long are you going to do this, because if you continue to aim for perfection, the goalpost will keep on moving, right? So what is needed is you do this, but then you deploy and seek regular feedback. And I don't think anybody is doing these prospective long-term not even long-term, right, but prospective clinical validations with human in the loop, but not utilizing in clinical decision, because that's where you learn what is happening without affecting patient outcomes. A lot of it is primarily stemmed because we are in this fail fast, fail forward ecosystem pushed by the VC ecosystem, where you have to show demonstrable growth very, very soon. Customer acquisition is an extremely important, you will agree, right? So this could be a middle ground, right, where you actually do these human in the loop evaluations, but don't use those in decision making, but learn from them very, very quickly so that you can test them, make your models better.
Excellent.
I had to say.
So I'm going to close the first round and bring it to Annie. So Annie does a lot of work in platform trials and in doing RCTs silently. So I would request Annie to tell a little bit about that, because I think the entire audience would have a lot to learn from that. And also close your remarks with a few non-technical indicators, which we have seen in the global setups, which are often things which help you understand the workflow adoption is actually happening or not, and whether the final users are being able to use it equitably.
I love what you said, because I was just like, I'm so glad that people are recognizing that. It's so wonderful. So the clinical trials that we are doing, like which are the platform trials, it's a 3-phase go no go trial, where the first phase is what I showed just here. It's kind of like the ones where we can do it immediately, because we are also failing fast and forward, it's in academia, and we are being pushed very hard because it's already in use. So there's a lot of like public good need to just follow on, right? So we do something immediate, which is get people to get into a room and just ask questions that are hypothetical, so that we don't have to wait for ethical approval. We just minimal. Then when we have identified, at least hypothetically, so it's called the HIP move, hypothetical move, we've identified hypothetically what is safe. Those models come in and useful. Those models then can go forward into our silent trials, which are our silent moves, where we are in the countries that we're in now. We as you were saying, we follow patients, so we recruit prospectively, and we also have retro move. We can do a silent trial retrospectively. So existing data, or we recruit a patient, consent them, and then don't use an LLM, but we see what happens in the background. Follow the patient up, so it costs a little bit of money because you have to call them up going, hey, are you okay? You got your diagnosis, you got your treatment. Are you fine after 7 days? And therefore we have an outcome because that's what a trial is. It's about actually following patients up and getting an outcome. Is this safe? We have to go beyond, is it accurate on some data set that is fake? Is the patient okay? Did they benefit from this, right? And then we use that and we ask our models retrospectively. You say, well, counterfactually, what would you have done? And this is what the silent trial is, right? And then the models that are good enough, then we go, no go. And then we have a randomized control trial, which is the ultimate evidence base in medicine. All of everything that you are using, that you trust in medicine in terms of vaccines, devices, are tested in randomized control trials, and it is a non-negotiable standard in medicine. We have to use that. And we can do this with moving targets. These are adaptive trials, and we just have to make sure that you get the right metrics. And those right metrics, we have to remember that what are we doing this for? And we sometimes forget when we just chase in these numbers all the time that this is for patients. We need patient-focused outcomes that we measure, and we have to follow the patients up and find out. And we are interested, as you saw from the name of the lab, humanitarian response, high-stakes settings, and very important decisions that clinicians have to make that have got very important consequences. So we measure things. Our trials are measuring things that are, the survival of acute illnesses. Whether a patient goes home with the wrong diagnosis and gets re-hospitalized. So patient-based outcomes that we measure by following the patient up to see how they are doing. And then clinician-based outcomes, which is the most simple one, which you also mentioned as well, which I thought was very important. Is it actually useful? Are people using your tool? And if your tool works really well, but no one wants to use it because it's annoying, because the button is not clickable, because they don't like the color and teal is less cool than green, well, it's important. It's really important. And we have to remember as scientists, when we are developing these tools, that it's no longer just in the lab. We have a responsibility to be cool, and we're not very good at it sometimes, right? Like it's not our forte, but we have to care about how the tools are used so that they are usable and that they are actually useful. And those two things I think are important: patient-based outcomes and actual usability. Yeah. But thanks. This is very, very nice to hear it from.
Thank you, Annie. I think key insights, we often focus on a lot of clinical outcomes and metrics, but patients are actually at the center of everything we do in healthcare, right? So talking about patients, Noora works with a lot of patients and caregivers all across. So Anubhav, you have deployed generative AI in real world, right? So how do people experience AI compared to the traditional human touch and human voice which they had? And also, how do you evaluate, or do you have a mechanism of evaluating these subtle human AI interaction signals in the real world in your setup?
Again, to clarify, right now, as far as the patients and the families, the end user is concerned, they still interact with our clinicians, right? The clinicians, then we have a subset of clinicians who are not using the AI tools, and then we have a subset of clinicians who are using the AI tools to understand the difference between the outputs and then the turnaround times, and are the responses that are being sent by the clinicians who are being aided by these AI tools, are those responses also better, are just like they are higher quality? There was a are they just like better quality, and do they enable the user? And this is again going back to a product metric that we regularly track in parallel with the model metrics, is retention. Are the end users coming back to ask us a follow-up question? Right? Because that's the true measure of, did they find the answer given by the clinician useful? And is, we are putting in so much investment in building these tools. Is the AI aided workflow increasing that retention, increasing the users to come back and ask a follow-up question? And I also want to say, why is that important? Why are we so interested in retention and in measuring whether the user is, is asking us a follow-up question, because that's the theory of change that we have developed. And again, that is one key step in these evaluations as well, which is defining the user funnel from acquisition to engagement to what after that. And our theory of change is that, we ultimately want people to adopt healthier behaviors that we are training through our in hospital programs and through our digital platforms. And unless we build a product which the users find useful and they're engaging with, behavior change will not happen. It's a long-term process. And so unless they're using the health tips that we are pushing, unless they are reaching out to us when they have a health concern, unless they see value in that, behavior change, long-term behavior change, which we care about, again, as a proxy to mortality, health outcomes, like long-term development health outcomes that behavior change will lead us to, that will not happen. Yeah. Did I answer your question?
I think fair enough. So you talked about like how the ultimate end user's experience with the product is like very important, right? And I see at least 3-4 startups here who are attending this, who are creating products. So often we see a lot of AI models in these softwares being developed by startups. A big point which they also are concerned about, and we all are concerned about, is privacy and security. So coming to Dr. Subhasis Banerjee, who has done extensive work on privacy and security in large public service applications. So I want them also to take something in this space from the panel. So I would request you to share a little bit about your experience in evaluating these systems, and when you transfer to healthcare, while evaluating healthcare AI systems, which are built on large registries, what are the architectural or governance level evaluation checks which you feel are essential to ensure both privacy and utility? I mean, I see Dr. Saini also here, who is building the NIMS repository. So I think a lot of people would be benefited from your takes on this.
Well, privacy is a hard one. Privacy is a little bit misunderstood in computer science. In all the years that I worked on privacy, I interpreted privacy as secrecy. I did not differentiate between the two fundamentally. But then came the Indian Supreme Court order, and Indian Supreme Court said that privacy is not secrecy. The judgment starts with that. And it defines privacy as a loss of control, loss of informational self-determination. So it says that when you are in a situation that your data is being used in a way that you don't understand and can adverse you effectively, that's loss of privacy. Now, that's a hard one. And I have to say that in computer science, we don't have any technique that can protect against that. Right? And I think that only after the judgment that line of research is opened up. And that judgment is actually accepted all over the world. So, right, so that's an expanded definition of privacy that comes from the legal team. So I would say that if you have to counter for that, unreliability will be a loss of privacy. Bias will be a fairness bias will be a loss of privacy, according to that definition. And from what Gokul was saying, every time you do bias mitigation, you're actually making a political decision, because there's an impossibility result in computer science that you cannot be fair to everybody and be calibrated. So this is an impossibility unless the data lies in a narrow manifold, and the medical data, which is underrepresentative, will almost never do so. So you have to make a conscious decision that who will you favor. That's bound to be a political decision. Not being aware of that is privacy hurting, right? So I think that if we have to talk about mitigation strategies, I think the mitigation strategy has to start with an articulation of a threat model, right? That what are the harms that are likely to be the result of your system deployment? Who are likely to get harmed? What can be the causes? And this will require an understanding of not only the technology, but also the people and the population on which it is being deployed. So it will require a very careful articulation of a threat model And I would say that that's the first place to start. So whether you can mitigate the threat is a different question, but articulation is the most important, right? And if there are certain things that are unmitigated, right, with the current technology, that must be recorded, that this risk remains. So I would say that there's a little.
Thank you. A very interesting take from Dr. Banerjee. And I'll take that cue and go to Dr. Gokul Krishnan. So we understand the difficulty in bias mitigation, but it's actually a very big problem, right? Bias. So how do you think we can really design this post-deployment bias and harm monitoring that actually detects these failure modes? And what would your response be to Dr. Banerjee's take on this issue?
I first of all, I will say great question because we don't know the answer to this. But I think just to kind of like give a taking a jab at it, right? So whatever metrics that we customize and design for a contextualized task can be used for monitoring to a certain extent, right? So in the real world setting post deployment, usually the problem is that you cannot do the monitoring case by case basis, usually because you don't have access to things like ground truth or what is the ideal outcome for this and things like that, right? So what you have to do is you have to do it in batches. So probably for like case samples of data, how has my model been performing, right? So whatever metrics that you have, you need to kind of repeat that exercise here, whatever you did for evaluation. So like Professor Banerjee was pointing out, the COVID detection accuracy went down after a significant amount of time, right? So that is one way of doing it, right? But I would add a couple more things there, right? So second thing is that you need to look at the robustness of the model, right? So the robustness is basically, is your model performing the same way consistently, right? So consistently in terms of performance, consistently in terms of the data representations, basically these are vectors or matrices, right? So is the data getting drifted? Is the prediction getting drifted, or your incoming data is getting drifted? So these are things that you need to analyze. And on top of all this, we should also ensure that whatever systems that we are having, the models that that are working as part of it should be explainable and or interpretable, right? Interpretable is kind of dream, but at least explainable. So it's like having some sort of a surveillance, public surveillance, maybe through CCTV. It's just there so that if some danger happens, you can go back and see what happened, right? Why it happened or something like that. So the explainability mechanism should be there to see, okay, what is causing this issue, right? When something goes wrong, you should be able to go back and say, for example, the COVID example, why did my accuracy go down, right? What exactly is the feature leading to this reduced performance? So that can be used in terms of bias as well, right? So what exactly is causing this additional bias for me? So as long as it is some clinical indicator, I'm fine with it maybe. But maybe if it shifts to some gender or race or something like that, then it's an indication that we should probably recalibrate the model, right? So these are some of the indicators that we can have for a continuous monitoring, and it's continuous monitoring, right? I don't think it needs to stop. So even and you was saying that it is continuous. We need to keep getting evidences of that it is doing good.
And you know what I like about that also, to compare it to a baseline. How much bias do we have as humans? A lot. And why are models biased? Because they're learning from us.
Right.
So how much is it actually? Yeah. And can we explain it when we are biased? If you go and ask some doctor, hey, are you racist? You know what they're going to say? Oh, okay, some of my best friends are, and so if you ask a model the same question, does it answer better? What is your actual standard that you're trying to get when you have that? And are we perfecting things too much? We should aspire to it, of course. We should aspire to it being perfect. but we shouldn't risk not deploying something that's probably better than our own biases. So, but I'm just saying, like comparing it, I really resonates with me. But
Yeah, sure. From a computer science machine learning perspective, bias is good. The term bias is actually the WX plus B term that we have in as part of your regression or something, right? The bias is actually
Without the bias, it would never have worked.
it would never have worked. So there is a thin line between this technical bias and the societal bias, right? So you need to find that line where it stops affecting the society in the wrong way. Yeah, I think that's a good point to stop. Yeah.
Right. So we talked a lot about the technical side, the clinical side, and before we wrap this session up, the final words I would like to have from Dr. Kshitij, who is also has been the sectoral expert for health and AI at CPMU, which looks at the centers of excellence on behalf of Government of India. So, Dr. Kshitij, you heard different perspectives. I think all of us would be really interested to know from a policy perspective, how do you evaluate what kind of AI tools and developments, even products, which the government is looking at for the various centers of excellence to develop, which you feel is important for the country at large?
So to give a brief background, right, the Ministry of Education is establishing 4 AI centers of excellence across the country. There is one in health and AI, agriculture and AI, sustainable cities and AI, and now education and AI. They are at IIC Bangalore, health is at IIC Bangalore, agriculture is at IIT Ropar, sustainable cities at IIT Kanpur, and very recently, education and AI is at IIT-Madras, very recently. Put together, it's a 1,500 crore project. So it's a big bet that the government is doing in these terms. So what we did when we had in the process of now establishing them, and things have also started moving, is since they are at academic institutes, we told them the metrics of evaluations is not going to be the number of papers published, right? So every quarter there's an eval. And he's smiling because we went and evaluated their center as well at some point, right? So we go every quarter and we do an in-person eval because we realize that PowerPoint presentations are always much more beautiful than actually looking at the work that is deployed. And so metric of evaluation, or saying that what is success here, is number of lives touched is a success. Number of lives touched positively is a metric of success. So anything that furthers that call is an important aspect to evaluate. So then number of papers is not important, number of patents is not important. What is actually important is number of deployed solutions. Now, when you say number of lives touched are extremely important, then you have to pick up the right set of problems that will be affecting a bunch of population, right? So for every domain, there is a different problem statement that we are looking at. So for example, in education, if you look at it, the primary problem in Indian education ecosystem is the foundation learning and numeracy. FLN, it's called foundation learning and numeracy, where a third standard kid should be able to do this much amount of math and this much amount of language, right? You should be. And if they're not able to do that, it affects their long-term life. It is not everybody ends up being a scientist or anything, but these basic skills are important in every profession that you get into. So that's an important problem from an education perspective that we are looking at. From a healthcare perspective, oral cancer is an important problem. Now, from oral cancer perspective, what is important is actually screening is very difficult in India from an oral cancer perspective. So the solution that the government is looking at is that can you develop a point of care image processing device so that you can identify which is at risk, which individual is at risk of cancer, and then make that individual become a part of the ecosystem where the patient can be followed up and evaluated more in depth. So while we as researchers are interested in very fancy solutions of identifying receptors on breast tissue and other things, from public policy perspective, we are looking at can we do massive screening so that we identify the real pain points which are affecting a large number of people, and those screenings can be done as cheaply but as effectively as possible so that identified individuals get into the ecosystem of being evaluated more intensely, because that is something that we're missing as a country. So these are the points of view from a policy perspective for the AI centers of excellence.
Excellent. Do we have? I don't think we have another round time, right? So, okay. Okay, so I have a couple of questions. So before I wrap up the session and give the take-home points, we can probably take 2 or 3 audience questions. Dr. Saini.
What you mentioned now that it prop actually one other is it pays the and I don't keep that percent. Problem level comes organic. It's a push from the top. There's not any tools that oral cancer. See, oral cancer is not a kind of problem to predict. It's an area so easily subject knows it. Subject knows it. There's no. What I'm trying to say is that you're trying to start a problem. Here I can, where it's subject itself will come and say I have a problem. Yes, exactly the problem is. You're not targeting the right problem. You're not identifying. It's not organic. One of the centers which you mentioned, no, which has got put for L. I work in the city. And I know I would have gone to harm of the district to please come. They don't ever come to a hospital. And that same hospital which intends to do AI-based work, no, they closed down the institute for 3 years, totally unscientific for a COVID.
So I'm not getting the question, sir.
Question, my point is that the problem is not organic. The problem that you give an example is not at all a problem.
So you're telling me that
Say, please visit the place, see the problem, actual problem at the ground, and then work on it, rather than coming from the top. Just because in India people smoke more in just very low quality this gutka, that's why oral cancer is more common. It's a well-known fact. There's nothing space science in it. I'm trying to say, work on the problems which are so basic, so easy to solve, but we don't have a solution to them.
But could you give an example?
I can give you one example. Digitization of hospital records itself is a problem. In India, not even 1% hospital have an cost-effective digital solutions. You go to a hospital, you know what happens? Today patient comes, he gets a scan done. His scan is, all the machines generated digital data that's converted into pills. All the pill companies which would have closed down if India won't have been there. So that data becomes, and data is deleted from there. There is no solutions, no data is preserved. Patient goes, he loses the film on way to his village. Next day, again, patient comes, you scan him again. No hospital is storing any data in public sector. Just, I can name 4 hospitals: All India Institute, Delhi, CMC, Vellore, Fitra, Tirunal, and NIMS Jaipur. Other than these 4 hospitals, show me data in any other hospital.
So for first piece,
Solution simple.
Yeah.
HIMS do not exist. Hospital information systems do not exist. How to create digital reports, we don't know. That one good solution came in India is Ognito. Actually, very good solution, which was a much better than Nuance actually, which we used to use previously. I'm trying to say, go down to the problem at the level. Don't try to come to the solutions.
So sir, this digitization effort that you're talking about, there is a huge effort that is going on in the cancer space. If you look at the National Cancer Grid and the Center for Digital Oncology, this is exactly the problem that they're trying to address. So now, given the diversity of the problem and given the scenarios that are existing, there are efforts that are happening in that domain. Now, whether a particular problem is not important or important or not is a decision that the center which gets the award to get it forward is going to decide. Right now, given the fact that you are saying that digitization is not existing, it's a known problem, right? And there has been a concerted effort from National Cancer Grid and Center for Digital Oncology to address that. Now, if that gets addressed substantially well, it will become more omnipresent across the country. It's a difficult problem to solve, and people are making an effort. But saying that an important oral cancer is probably not an important problem to solve because it is a top-down problem to be addressed. There are multiple problems that the country already has. One problem has been picked up by a particular center. A center is not going to address all the problems that the country is suffering from. So the point that I'm trying to make is, while there is a center of excellence which is trying to solve a problem, which is an important problem, might not be the problem that is you're facing day in, day out. There are other efforts in the country which are trying to do that. A single center, for example, Koita Centre for Digital Health, Ashoka, will not be able to solve everything. And Koita Centre for Digital Health in IIT Bombay will not be able to solve everything. So there are concerted efforts now in the country which are trying to solve individualized problems once the scalability, let me finish. So once the scalability problem, once the feasibility of the problem is addressed, it could be then taken at national level. That's what I'm trying to say.
My point is that take up those issues which will actually have a mass level effects.
That's what I'm saying.
A single isolated individualized problem. That's what my point.
Correct. So it also depends on the mandate of with which each center is coming up, right? The mandate of these centers are to work on non-communicable disorders. Now, given the mandate of the center is working on non-communicable disorders, they will not pick up the problem that we're talking about. But there are other initiatives in the country that are really working on those problems, and those problems are being picked up. Really depends on the mandate. For example, in NIMHANS, you cannot tell NIMHANS to work on cardiovascular health because it is working on mental health. It's a question of the mandate with which the mandate has been awarded to a particular center.
And can I add in here, because I feel like this is actually something that's represented in so many of these panels that I attend, and in so many, because we're going in a whole lot of different countries. Such a common problem. Doctors want to be recognized in decision making, especially in digital health and AI. I want to be like this, and I totally get your point. Like you have to be pragmatic with what are your expertise around you, what are your resource around you, who's giving you the money, which is the central problem. But the point is that there needs to be more outlets for doctors to come together to participate in the development of tools, from the development and including the recognition of the use case that is going to be worked on. And there's this frustration that builds. It goes like, why are people not listening to us? We are the people facing the problems every day. And there's this, and this is also, I feel like it resonates. That's why the move, when we're going to different places and we're running the move, people like almost feel relieved, like as a doctor as well. Like I was also desperate for it. And it's like just to have this outlet to say, like, I can, at least there's one technology or something that I can put my own use case into it. And every specialty has got their own baby that they want to, their own thing that they want to develop. And I think this kind of like framework, if we can get people together and get them to decentralize the decision making on like how these tools work, I think we actually have an opportunity now with these AI tools that you think that doctors can communicate with, and it doesn't have to be top down, and we can actually do something from the ground up, from where the problems are coming, by giving our voice into these tools that actually can listen to us and we can nudge them. And it just resonated with me because it was really one of the things that initiated the move. It is this frustration. I'm like, how can we better represent voices of the people who are actually needing to use these tools and have that? So anyway, I just think it's a part of a broader problem. Yeah.
No, I completely agree. I'm getting nudges to wrap up the session. We'll take one last question from him, and then probably I'll just give the 3 takeaway points from here and we'll wrap it up. Yeah, please.
Dr. Banerjee, I really appreciated your segment about survey. My question is perhaps an inverse problem. What if I do require, not me, I mean, the nation does require a certain amount of surveillance and monitoring for these technology. So I learned from the presentation that doctors are already using a certain amount of AI that they already just trust with a certain amount of capability. Then what is stopping me from then going to these platforms and say, I'm just taking an example, say, okay, tell me how to make a poison. Tell me how I can make the cleanest way to kill somebody, etc., etc. These like medical tools that I can use at already pretty highly sophisticated level that I can then misuse for some other reason. What if there is a need for surveillance in that aspect?
I would say that a personal misuse is a non-issue. You could always misuse it, right? I mean, if you ever kill somebody, just pick up a gun and shoot. So that's not a reason to stop AI research at all, right? And I would say that AI is such a thing that is unstoppable. It's a thing that has started. It's a remarkable thing. If you had asked me 5 years back, can there be language without grammar? As a true student of Chomsky, I would have said no. But that's proven wrong, right? I mean, OpenAI has no clue of grammar. It doesn't know grammar from hole in the ground, but it is so code. So I think that its internal representation, the embeddings are phenomenally good things, right? And putting them into public good is a great idea. So the question is that how do you do that correctly, right? There are great risks in doing that, and there are great benefits in doing that, right? So I think that as a computer scientist, I would say don't be anecdotal, right? An anecdotal approach is the worst approach to take to the problem, right? What to measure cannot be defined unless you have a threat model. Right? Articulate the risks, derive the measurement model out of it. So unless you have a risk model, so the standard is proportionality. There's a public good at one hand, and there's a risk at one hand. You deploy it if the risks are lower than the benefits. But evaluation requires a correct articulation of the benefits, not anecdotal, not that I believe that it will do good, right? There has to be a grammar in which you claim a public good, and there has to be a grammar in which you articulate the risk. Only then they can be compared, right? And you will not know what to measure unless you have articulated what are the risks, who are going to get harmed. That is all. Yeah, that's the way to go.
And if you have like someone develops a washing machine, some idiot is going to go put a cat in it or something stupid. This always happens. Someone develops a wheel, someone's going to ride over someone and they might kill them. But you don't ban the wheel, you don't ban the washing machine. You really just put that person in jail wherever they need to go. And I think that doesn't change. The technology doesn't change the consequences that people have to face. They use technology to do harm. And I still think that the judicial system works regardless of how the technology does. Still means that we can put guardrails on. You can put speed limits up, and it's not an intractable problem. You can follow some things that models do wrong and try to limit them, and it has been happening. But we don't want to damage technology.
I think we'll take the questions over lunch. We have a very good lunch. We can discuss with the panelists there, but I have to wrap it up. So a couple of takeaways from the session today is we are gradually moving from static pre-deployment evals towards post-deployment evals. The metrics are extremely dependent on the tasks, and patients are central to whatever we are evaluating. We talk a little bit about the importance of confidence scores and uncertainty in generative models. And for addressing that, we need our models to be more contextual, and also we need to develop robust models. And we also touched upon the importance of explainability in those models to address that. Finally, human in the loop, as we are deploying these models, is extremely important. And silent trials have to, silent evaluation has to keep on going in the background. We also talked a little bit about the challenges in bias mitigation and how it's, as Professor Banerjee said, an impossibility to mitigate bias truly, and how impact bias from a technical point of view is essential for even creating the models, right? Finally, from a public policy perspective, we realize that ultimately more than the papers and publications or patents which we have, the government is looking towards the number of lives your AI models and softwares are touching, and finally use these AI models to actually identify the people who need to be treated or catered to, so that we can become a prosperous country with the help of AI. With that, I'll close the session. Thank you, everyone, to the panelists, to the audience for coming, and I think we can discuss more over lunch. Thank you so much.
I would like to call upon Dr. Radhika to felicitate the speakers and auditor. Computers use visiting the monitors. We do that. When we do that.
The wardrobe malfunction. Be careful. I'm quick to just hold this up here.
That's it. Very.